In order to share them with you, I have to make a little, very quick introduction to to what in theory is happening in the knee. The osteoarthritis is a very big thing. It has 500 million patients of osteoarthritis in the world right now. So it's a huge thing. And so far, the people is not convinced that there is a disease modifier. So something that can change the course of this, the course of the disease. But we'll get to that. Osteoarthritis is an inflammatory disease. It's a low-grade inflammation. It's not like rheumatoid arthritis, as you know. It's a low-grade inflammation that happens with time and goes all the way to the destruction of the whole joint. And this happens through the activation of the immune system inside the joint and the activation of the proteases, hyaluronidases, collagenases that chew completely the cartilage of our patients. So what we want to do is we want to reverse that. Another important issue is the fact that the synovia is what lets the immune system get into the joint. So the synovia can stop the entrance of the immune cells that do sustain the inflammation or not. So the fact that the synovitis goes with osteoarthritis is very, very important for what I have to tell you now. Let's get to the point of what are the grades of osteoarthritis, so that afterwards we are clear on that. We do the diagnosis through standard X-ray. We do the diagnosis through MRI. Many of our patients don't, care to do a standard X-ray. They get all the way to my office with the MRI. Do you have an X-ray? No, I just have the MRI. Is the MRI not enough? So I have to make sure that in MRI, in standard X-ray, the things are clear. Kellgren-Lawrence radiologic classification, grade 4 is large osteophytes, joint space narrowing up to bone, severe sclerosis, deformity of bone ends. So this is what I mean for grade 4 Kellgren-Lawrence. Osterbridge classification was born for arthroscopy. And so it looks at the surface, only the surface of the joint. So it's been used also for MRI, and in MRI and in arthroscopy at the same time. Grade 4 is exposed subchondral bone. I will say grade 4, which means Kellgren-Lawrence, and as well means MRI. Many conservative treatments are there. The ones that are normally recommended by family doctors. The NSAIDs treatments, corticosteroids, which are in big discussion now, hyaluronic acid, PRP, monocytes. At some point comes out from the US, mesenchymal stem cells from donor and commercialized. This is the first thing that we don't use in Europe for regulatory reasons, but I will not get into that in detail. And then there is minimally invasive surgery. Minimally invasive surgery means to do something in the OR with the patients And for the knee, we can have focal lesions or diffuse lesions. In diffuse lesions, stromal vascular fraction from autologous adipose tissue has been suggested, starting from Korea, Vietnam, and the Far East, where it was, it's been and is still very popular. Stromal vascular fraction means treating with collagenase, with an enzyme that disrupts the fat and leaves the cells free. This is something that, for regulatory reasons, in Europe is complicated to do. It's a long procedure. It's a procedure that leaves collagenase. It leaves an enzyme into what you're injected in the knee. So it's not the best thing that you can possibly do eventually. And the regulatory institution agree that the minimal manipulation would be more effective and, in fact, more rapid to produce mesenchymal stem cells. Mesenchyme is an embryonic tissue. Mesenchymal cells are not in mesenchyme in the adult. They are scattered in various organs and tissues: bone marrow, adipose tissue, synovium, tendon, and so forth. They are a potent differentiating cells that can, in fact, differentiate into many osteogenic, chondrogenic, myogenic, tenogenic lineages. It's very potent, but its potency, it's not only towards differentiation into different cells, but also in releasing paracrine factors. These factors are working towards reconstruction together with the cells themselves to the environment that these cells are in. The factors that are released change in the function of where the cells are. So if you put mesenchymal stem cells into fat, they have a pattern of release. If you put them in the joint, they have another pattern. But they still always do stimulate the immunomodulation of inflammation. Why? Because you have to turn off inflammation in order to reconstruct. If you don't turn off inflammation, you don't reconstruct. So these cells, as Arnold Kaplan, who first described them, says, are a drugstore, a manager, stimulating various populations in a specific fashion. Medicinal signaling cells, they were called. So that's why. What are the sources of mesenchymal stem cells? They can come from adipose tissue. They can come from bone marrow. Adipose tissue, you can collect much. Bone marrow, you can collect maximum 10 mLs. Otherwise, it's impossible. It's impossible to do. The maximum you can obtain is 10 mLs. Maximum you can obtain is a tin of Coca-Cola full of adipose tissue. Very easy to do. Adipose tissue is preferred to other sources because it's easy to access. It doesn't give you much pain to do the harvesting. You have an anesthesia, and after the anesthesia, and it is richer in stem cells, so much richer than bone marrow. Bone marrow, MSC 10 to 80, adipose tissue, MSC 200 to 50,000, depends on the patient. There is a variation, but the amount is always outstandingly more. These are very, very old slides. I got them because the message is the same. These are studies that haven't been redone, and this one as well is very important. What happens to the elderly? In the old people, the mesenchymal stem cells of the adipose do better in chondrogenesis than the bone marrow derived. The aged adipose-derived stem cells grow as young adipose stem cells, while aged bone marrow stem cells proliferation is impaired. So they are bioavailable, high proliferative capacity. They don't get old fast as others, which means they have high telomerase activity. It's a technical way to say that. They stimulate and they immune modulate. Where are they? They are on the surface of the vessels. They're called pericytes. And when they get out of the vessels, by chemoattraction, by stimulation in normal conditions, then they become the real mesenchymal stem cells. But they are on the vessels. So what is interesting is that you have to suck the area where the vessels are, the small vessels of the tissue, and then you have to do something to either digest them with collagenase, and this is called SVF, as I said, stromal, vascular, because they come from the vessels, fraction. Or you can mechanically disrupt them, as in lipogems. Collagenase digestion is not a straightforward operating room procedure. Collagenase remains there, as I said. It's something that has to be done outside of the OR, so it's something that's not easy. The minimally manipulated adipose tissue that we obtain with the manipulation with lipogems is instead very easy and can be done in the OR. The company started selling the kit in 2013. The kit you saw, this is someone doing the preparation. This is the kit you saw. There is a nice, easy recipe. What I normally do is infiltrate 240 ml of Ringer together with adrenaline 1 to 500. Then I aspirate 120 ml, half of it, and then I put that into my lipogem extraction kit, and I obtain an average of 60 ml. What do I do with 60 ml? I can infuse 2 knees. 1 knee, normally I infuse with 30 ml because I do the maximum possible stimulation that stays in a normal knee without impairment. So this is the infusion. Okay, with a small cannula. And this is a bigger cannula that I use for liposuction. Nice and easy procedure. We do it with the syringe because the syringe allows you to be more gentle in the suction. I do not use the procedure. This is what comes out. It's a very nice yellow material. Okay. And the material goes directly to the OR nurse. The OR nurse treats it. Okay. Okay. This is the disrupting. She does the disrupting. Okay. And after that, she obtains a concentrate.
A questo punto apri sotto, apri, chiudi e spari, bravissimo.
Whatever. We tested every single patient for the amount of cells. All the patients went through this nice and expensive machine, which is a multi-channel color, whatever, fluorescence activated cell sorter, which says how many cells come out and how many are really stem cells from mesenchyme. the main number of cells that I put in a knee is 30 million, of which 14.2% average are mesenchymal stem cells. If I take these cells and I don't put them in the patient and I put them in culture and I stimulate the cells in various ways, I can obtain bone, I can obtain cartilage, and I obtain a proliferation of the cells. The histology. At the beginning, we started looking at the failed patients where we had maybe implanted we implanted the prosthesis, and then we took all the pieces, and we saw that compared to non-treated patients, we saw some new tissue. And this is failed cases, right? This is patients that did not respond. So it was impossible for ethical reasons for us to do other different studies in the human, but we could see, we saw something. And we saw more on synovium. So my idea is that many of the mesenchymal stem cells attach to synovium. Attaching to synovia means sealing the joint from the inflammation and modulating the internal this joint chamber from the inflamed, from the immune cells, and this is what actually happens. A and B are two cases from patients that we implanted a knee prosthesis on, not treated. And C and D are two treated cases with MFAT, which did not have a good result. They were operated on, and we studied the synovium. The synovitis is dramatically reduced, and this is a published paper, in patients treated with MFAT. So even if the results are not good and the patients still want to do an arthroplasty, but still we can see and measure the efficacy of the extract. MRI, more difficult. I'll be quick with that. MRI means studies that need at least 2 or 3 years follow-up to see something, because what we expect in studying with the MRI is to have a rejuvenation of the knee. It's difficult to see that. We don't see that. So the MRI studies fail to demonstrate an efficacy. But the point is, if you do look closely at focal lesions, as in the right, you can see this runner, 32-year-old, he has a hole in the cartilage, and he is treated only with MFAT from lipogems, and at 32 months, the hole is completely healed, and there is no edema anymore in the bone. So he healed, actually. So we can demonstrate that, but it's very difficult. What is easier to demonstrate, I think, is to demonstrate that the evolution of the osteoarthritis is blocked by treatment. And good responders have this follow-up always. So we are collecting them. We're trying to do a program in order to evaluate scientifically the difference at time 0, 4 years after treatment, 5 years after treatment, and we are trying to collect results. The procedure is automatic. It's easy to do. It's sterile, and it allows to keep the niches, the areas where the precursors of the mesenchymal stem cells are, gently and at biological grade. Sterile. In general terms, sterile means that you can put them in the laboratory and grow and you don't grow any bacteria. So technically, they are sterile. But don't think that sterility is such a standard thing as the lab. So you might still have some bacteria in it. So in the pre-surgical recommendation that comes with sterile is do not combine with any metal surfaces, because on the metal surfaces, also one bug is able to create a colony because there's no inflammatory defense. So I would not recommend to do hemiarthroplasty and associate it with lipogems. In pre-surgical recommendations also, address concomitant tissue, instability, axial defects. You cannot pretend that this patient can do well with lipogems without anything else. He's a dramatically varus knee. Did the patients undergo pre-surgical physiotherapy? Did the patient undergo PRP? Platelet-rich plasma is useful to figure out if these patients are responding, because it's a biological treatment that is pretty much based on the same thing, doesn't last much, but you have to collect these data. You have to understand that a PRP responder is going to be excellent with lipogems. On a compassionate basis, we treat patients with grade 4 osteoarthritis, elderly patients, or other patients who are willing or unable not willing or unable to undergo arthroplasty. But normally, we don't treat, at this point, grade 4. MRI grade 4, X-ray grade 4. Our surgical routine. We ask patients to arrive at surgery after a few days of rest. We want to have a very quiet joint. We don't want to have a coffee machine on the fire. We want to have a joint that is friendly towards the cells. We discharge the patients within the same day. We leave them on crutches for a week. We use a girdle when we do an abdominal suction. We use the girdle. We can also do a thigh suction. That's is easy. But normally we do abdominal. We do a brief antithrombotic therapy with low molecular weight heparin. The surgical pearls are no local anesthetic for the abdominal infusion because we found it to be slightly cytotoxic for the cells. We normally do high spinal anesthesia. These allow us to do the other thing, which is always perform arthroscopy because it washes well, solves minor imaging undiagnosed conditions, identify lesions, and can further and thoroughly wash away inflamed synovial fluid. Exclusion criteria: age over 70, BMI over 30, Kellgren-Lawrence osteoarthritis grade 4. Possible adverse events. These are the patients that you might see 2 or 3 days after treatment. They have hematomas, they have ecchymotic skin. It's nothing to worry about. Most of them don't, but many can have. We treat them with a heat pad. In 2 weeks, they totally solve the problem. Infection, we never saw. We did not have any infection either in the knee or on the abdomen. Knee swelling depends on the amount of the infusion. Usually, it resolves very slowly because what you put in is a tissue. It's not just synovial fluid. So it stays there for long. If you plan to infuse a lot, you have to plan to tell the patient that it's going to be swollen for a lot. Temporary adverse events. We noticed in asymptomatic and patients that were doing imaging for other reasons. He had a sprained knee after the surgery. He's a man, and he he did MRI, and the radiologist called me and said, there's a lunette that I see. I don't know what that is. What is this? And it's an adipose articular lump. They disappear. In this case, it disappeared in 3 months. We did another 2 MRIs, and at the 3rd MRI, nothing was there anymore. Temporary adverse events, lipoma arborescens. Another thing that didn't give any symptoms. The patient had this slight swollen area over the patella, so he wanted to figure out, I wanted to figure out, he had this kind of lipoma. I think it is due to lipogems. I don't know. We followed him. The arborescent lipoma, is crazy as it sounds, disappeared. We had a recent adverse events, an organized adipole lump. This is due to the infusion. The patient feels it, and we're following him up. This is out of 300 patients. So it's an event that is very rare. It might happen. It's going to disappear. Otherwise, you just do an arthroscopy and take it out. Other possible long-term adverse events, adipose dystrophy on abdominal wall. Many of the patients would not watch themselves so closely to figure out a defect like that. But this is a relatively young and beautiful woman, and she looks at their belly, and there is this thing. And obviously it is an adipose dystrophy, and obviously it might be due to the uneven harvesting. So my problem is not being very even in harvesting the surface of the abdomen, okay? So then patients ask you, but is it safe to do such a procedure, because it might be stimulating tumor cells to grow, or they must be themselves become tumor cells, okay? So I always tell them this regarding this huge 2,000 patient study that was done on women after breast cancer, where they had 2 types of reconstruction. One reconstruction with a silicone prosthesis, one other type of reconstruction using lipofilling. There is no difference in recurrence rate. Eventually, a little more recurrent rate in silicone prosthesis. So there's no cooperation between tumor cell, eventually tumor cell, and adipose tissue extract. So we are safe on that side, okay? Our follow-up study, and I'll wrap it up. 1 year, efficacy 90%. 4 years, efficacy 55%. And these are all, this is all done on patient-reported outcome measures. 1 year study, 100 patients. They did not do anything but infusion of lipogems. 6 months, 12 months assessment. PROMs show that the pain goes down, the performance of the knee goes up, and the motion increases a little bit. What are the negative outcomes? The age of surgery, negative outcome. It's a predictor of negative outcome. Another predictor of negative outcome, somebody you can say, this case can be a case that is not responding well, is synovitis. In high-level synovitis, the patient have the tendency to do worse, to perform less well than other patients. 4 years follow-up. Efficacy 65%, but this is an older case report, cases from 215 to 218. I was using grade 2, grade 3, and grade 4. If I take out grade 4, sorry about that. If I take out grade 4, the efficacy gets much better. So we have a good response, a good result at 4 years. And next year we'll publish 5 years follow-up. The poor outcomes were treated, 50% of them were treated with joint replacement, 25% was treated with hyaluronic acid, and 25% were not treated by us, or we don't know what they've been doing. And at some point, we follow them on the phone, but we might not have been able to follow them anymore as patients because we didn't have a good result. And this goes pretty much together with what the literature say. We have systematic reviews from last year or the year before, and in total, these meta-analysis had investigated 29 studies, 600 over knees, and the results are pretty much similar to what they had, using SVF or MFAT, using and the effect was worse when there was complete cartilage loss and very important osteoarthritis. Controversy. There are not common aspects in inclusion criteria. We can have a lot of different views, a lot of different preparations, and that's why the literature is not so homogeneous. It will become homogeneous. There's a lot of people that publishing now on the matter, and it's going better and better. Open question: how long does this effect last? We do not know. We have come all the way to 5 years now. Are these treatments cost-effective compared to arthroplasty? This is a very important point. This is a point on which the sanitary policy is reasoning now. Are we paying for this kind of treatments for all of the patients? Is it worthwhile? Is it worthwhile in order to avoid arthroplasty? Arthroplasty is very expensive, and the complications of arthroplasty are even more expensive. So my idea is that they'll come out with some results on this area very soon, and if we can afford, we must treat many patients with the right indication with this device. What is the age limit? We do not know. We use to have this age limit of 70, but we still do treat patients that insist on being treated because they cannot undergo arthroplasty, and then we treat them and we keep the data. Treatment and keep the data, and eventually at some point we'll figure out what happens. Take-home message. It's an articular single dose injection of adipose tissue and is effective up to 4 years. Adipose tissue-derived products reduce the osteoarthritic evolution of the knee and have a role as anti-inflammatory modulators. Adipose-derived stem cells can be proposed as a real disease modifier in knee osteoarthritis. In terms of efficacy, degree, and duration, there's new possibilities open, one of which is the adipose tissue banking, the freezing and the thawing and the reinfusion with time with using liposomes preparation. This is possible, this is feasible, and we have done that already. Thank you.